14:30, so I would like to invite Francis da Silva from CGI up on stage. Welcome up.
Thank you.
Francis will tell us more about care at home, the accelerating delivery of people-centered remote care. And Francis, you may introduce yourself and get started on your presentation.
Thank you.
Thank you.
Welcome to this session. There have been some pretty interesting presentations earlier today talking about health systems. The title of my talk is actually something around what we mean by people-centered. People are patients, next of kin. They're also caregivers, informal, formal, specialists. So people-centeredness is about focusing on people and not the institutions. We need institutions, but it's not about institutions. Remote care has been known as telemedicine, telehealth, and it has many words. What I'm going to talk about is, and the terms ecosystem was mentioned earlier today. I'm going to talk about how these could be put together in the context of the health system. So my talk has two sections. The first, I set the context of what is a health system and trends, and then I talk about what is care at home, the framework developed at this research project that I've been part of. So, before I start, let me start with my conclusion. And my conclusion is captured in 4 topics. Health systems are complex. There are extremely a high number of components, but it's also manageable and it's understandable. It's not easy, but it's not impossible either. Federation is a good thing. The German-Swedish discussion talked about federation. There are different kinds of federation. German federation is different from Swedish and Norwegian federation, but federation and decentralization is a good thing. Standards. Standards is one way of making sure that knowledge gets into products and products can then implement them and they're open for scrutiny. So standards and standardization is a good thing. And of course, incrementality means that you gradually build solutions and products, and those products evolve continuously. So incrementality is a good idea. It's specifically for the health technology market. At first glance, Scandinavia looks very similar. You know, about 85% of our healthcare is funded by the public sector, which is taxes and other forms of contribution. So mainly publicly financed healthcare, single-payer systems. But if you look at the differences, they're pretty significant. In Norway, we've got 356 municipalities and 4 health regions. Sweden is better off. They've got 290 municipalities and 21 regions. And Denmark has 98 municipalities and 5 regions. I think Sweden is probably a little more mature, in my opinion. It's very personal, because they have a pretty decent ratio, roughly 1 to 12 region to municipalities. Norway has about close to 90 municipalities of different sizes. The implication of this is that you have a lot of governance challenges and the way systems and products are procured. I will touch on to these, but these similarities and these differences are an opportunity for the healthcare industry. So what is a health system? And I'm not going to get too academic, but I encourage everyone to just spend a few moments to find out, just Google, use Wikipedia. What is a health system? A health system is buildings, peoples, policies, plans, the motivated workforce, the population. These topics were mentioned. It's a combination of all these aspects. And you see, it's the supply of medicines and technologies. And those are part of the health system, but they're also the industrial component of that. And then we have these words like health plans. We don't use them often in our part of the world, but a health plan is a way in which health is provided at a certain service level. So you know what can be delivered. So we do have health plans in our part of the world. We just don't call them health plans. People know of health plans from, you know, your subscription to gold, premium, or bronze levels of services. And the last is evidence-based policy. So the way policy is framed, and the talks earlier today, we talked about these aspects, about how you might change legislation, how you might make, you may frame policy so that you can drive healthcare services and that you can actually generate profitable businesses supplying those technologies. I have, in my work at this research project, tried to put together what I call the building blocks of a healthcare system. You start with the laws and regulations, a population to be served, the health plans that will be served to these populations, the workforce that will serve those health plans to those populations, the funding and financing model, how you get paid for healthcare services and how it will be delivered, the technology, the biologics and the medical, the medtechs, the biotechs and the infotechs, the products that will be delivered to deliver the healthcare plans, the research and education, the enabling infrastructure, both buildings and the digital infrastructure, and the leadership and governance structure, which I referred to earlier about having, how do you have local services delivered and national level plans, how they harmonize. The dark blue, the dark purple, or the darker purple components are what the WHO has referred to as building blocks. There are 6, and the 6th one comes here, which is the backplane. It is all the health information systems that enable this. So I just thought I'd get that out of the way, because I think once you understand health, the health system, the next aspect that I want to set the context on is what is a health technology. And I think it's particularly important that people get this, because health technology is organized knowledge and skills. It's the application of that. So everyone building products pulls in, whether it's a vaccine or a medicine or a device or a software or a routine, that's knowledge, that's practice. That knowledge is then approved through something called a health technology assessment process. So health technology, the potential for that is immense. But it must be put in a right context in where it fits into the health system. So it means that policymakers, people doing procurements, people issuing requirements, need to understand what they are procuring. This is a graphic I put together just to position what I see digitalization and how that will be challenging the health system. It will be challenging it because data will be coming in all sizes, forms, formats, speeds, and people are going to be using the devices that allow them to be more involved. That is going to challenge them because there'll be privacy issues. It's also going to challenge the healthcare system, the healthcare providers, how they will manage that system, manage that data flow. But these are also opportunities for the healthcare industry. This is the backdrop of what got me working on Care at Home. And Care at Home was basically was created as a framework following research at this Center for Connected Care at the Oslo University Hospital. 17 partners from industry, from care provisioning, from municipalities and hospitals, and researchers from business, technology, and architecture and design, the architecture school. And they were focusing on different aspects of what is needed in the healthcare system. What is the nature of healthcare innovation? So this research community, and there's a link to the site. I encourage you to take a look there, material and findings, because I think they will help inform a lot of what was being said earlier today on ecosystems, trade, and so on and so forth. This project looked at how we might bring health technology innovations to change and enhance and enrich the health systems. Okay, with that background on the system, the research, and what we mean by health technology, let me start with care at home. So care at home is nothing, I've used an old policy document from the WHO that actually tried to point out what are the problems of the healthcare system. This was developed and published in 2015. It worked on much before. It was ratified in 2016, and there has been a consistent push. How can you break down these curative silos of care delivery and actually look at ways to get people more involved in the decisions about their health? So care at home actually addresses three very distinct contexts. The first context is, sorry, this was not the context, but if we start with people who need care, if we put them at the center of what the healthcare system will do, the first context is the context of all the care providing and service providing entities, whether it is patient transport, whether it's patient rehabilitation in a gym, it's nutrition, it's acute care, it's primary care, it's specialist care, different service providers, people who fix people or serve people, there needs some form of coordination among themselves, among those actors. There'll be needs for legislative changes, but that's one context. They're the care providers. Then comes the context of Then comes the context of the backplane of all the folks providing the technology products, the organized skills put together, whether it's vaccines, it's medicines, it's logistics systems, it's EMRs, it's EHRs, everyone producing products, serve them. I suggest that there is a digital equivalent, a digital twin, a digital equivalent to coordinate this, to simplify this. This digital platform has two functions. It functions as a marketplace and it functions as an orchestrator. Earlier there was a mention of interoperability between Germany and Sweden. Interoperability plays a key role. It facilitates this kind of data sharing. It facilitates this kind of marketplace development, this type of orchestration. To put this form of orchestration in place with the products that will be serving each one of the individual service providers on the pink area, because they will have their own systems. The digital platform orchestrates and creates a marketplace for continuous growth. But what is needed is also a design, build, run, operate, continuous cycle of continuous improvement, which is what I would call the third context, which is about professional service production. There tends to be a conflation of these different contexts. This is just a suggested approach to how we might understand the different roles, the different logics that is needed to do this kind of, to enrich the health system and thereby transform it. Because different people are doing different things, but they're all working towards a common goal. I find in my work, I've seen a lot of this kind of mix of roles causing more confusion than clarity. That's why this arose. The next slide is a little busy, but please bear with me. If we go with this systemic graphic, I propose a digital platform, an ecology of platforms, because there will be different solutions. There's not going to be this one size fits all, one solution. If we start with people who need care, they will seek care in whatever way they can, and they will reach out to care providers in their different sectors. Each sector will be regulated differently. They will be governed differently, they will be budgeted for differently, they will have different KPIs and so on and so forth. But they need to be integrated. We need to provide one form of integrated care. There was a mention made about integrated care systems in the UK, NHS creating integrated care. In Norway, we have something called Helsefellesskap, which is still very, very, very early, but it's trying to get into that direction. So you need some form of integrated surface, and you need a corresponding backplane to do the data integration and data sharing. And what you need then is, you then need the interoperability points to share data between the different actors and aggregated at the point of need and shared at the point of responsibility. So accountability will always be at the accountable care organization. And we don't necessarily have these today, but we should be working in that direction. I think in Sweden, the regions could take on that responsibility on behalf of the municipalities. And the ratio I mentioned earlier could work in that way. But those regions will then need products that will be served and integrated and put together. This graphic is only showing how the service delivery will function, the so-called runtime setup. What is missing and what is needed equally is what I call the development and operations, the continuous development and operations of the platform, so that you have this continuous evolution of the platform, the products, continuously. There will always be new products. With just looking at the flow of data and the volumes of data, we will have new products coming in. So this graphic is just one way of depicting how interoperability might work, what is the need of and role of standards, who are the people who would be doing standards, how might you have the marketplace working so that people can deploy their solutions in this marketplace so that they can be used by users much faster than the 6 to 9 month procurement cycles that we see. How can we experiment, test, and deploy? So this is the essence of the care at a whole framework. But how do you go from doing working in an ecosystem, working in these different contexts? This approach that I'm suggesting suggests that you start with an understanding phase. Design thinking has been used, but design thinking tends to focus primarily on the thinking, and in lesser degree to design doing, even though design thinking talks about design doing. But so I suggest you start with the organization that has the need. The moment they see the needs don't fit within the confines of their organizational structure, they reach out and work to collaborate with others. So you go out of your organization, but you're still anchored in your organization. And then you go through a sequence of strategizing where you're trying to frame the problem, you're trying to understand the needs. You then go through a prototyping phase where you actually create mock-ups very quickly, and you then go into delivering incrementally as fast as possible. This is an extension to the triple diamond model, and and for me, the most important aspect is actually adding the circle, the operations, because that's where life is lived, that's where solutions operate, and that's where care services are delivered. This is an example of one of the partners in the C3, the Center of Connected Care. Through an innovative partnership project, they try to address the need for providing a product to a hospital and their municipalities to help cancer patients track their care conditions and prepare before going into the hospital for chemo or other forms of therapy. They have devised an app called Nimble People for consumers, for individuals, and the same company has developed an app for the healthcare workers. So there are two sides, two user groups working across the same solution. In the middle, they've teamed up with Roche to create a a card that can fit onto a mobile phone to show how you could use nanotechnology, use different forms of IoT and sensors to actually capture these data points that are relevant for treatment. If you are a cancer patient, your signs of infection, you do not go in for your treatment. If you do know that in advance, you do not do the preparation of the chemotherapy, the dosage, and you save money because you do not pre-mix this, the necessary treatment, the medicine. So these two, there are other smaller vendors, product developers behind this, but they've put together a consortium that has created an app, has created devices, created the necessary data protection components, and then they're working with another context, which is not the health technology, but the health service provider context, where they're working with the municipalities, the hospital, the department for oncology, to address our needs. This is just an example of how you could get people to be at home, get treatment at home, but still be connected to the hospital. So in conclusion, I would just say that to serve people, both patients and their next of kin, and to serve healthcare providers, the people working in the care delivery, you need to have some kind of structured policy and knowledge-based, evidence-based policy, which is on the left-hand side here. But you also need to feed into the manufacturing and the retail sections of the healthcare industry. And so if you can recognize that there are two, if one recognizes that there are two sets of actors, the policymakers and the industry, you then need the connection to be able to generate this kind of innovation and shorten the time needed to bring products out that are relevant. So this is just a simple effort to identify the different stakeholders and make sure that we are not conflating things, we are not messing up the flow of how technology is developed and how technology is adopted and how needs are assessed and how needs are validated. So my closing is the same. Health systems, I think we need to get our heads around health systems. It's taken me some time, and it's an under-communicated aspect of health systems, of health infrastructures. Federation exists in different ways. It all depends on how you are legally governed. So European health data spaces may have some interesting challenges on the legislative processes, I think, but maybe decentralization and federation could help that. Standards, you can never have enough of those, but you should have just enough standards so that you don't get regulated out of business. Incrementality is good because you really don't know everything a priori. You need to understand through participation. So that was just a few minutes of questions, if there are any.
Perfect.
Yes.
Please step ahead to the microphone so everyone can hear you. Have a few minutes for questions.
Thank you very much for your presentation. We're doing something very similar to what you've described here the last 4 years around that digital platform. And I guess my question is, what do you see the implications being for electronic health records? We just had Cerner in 30 minutes ago talking about how they're trying to join up journeys and so on. Do you see them being relegated more to a system of record where the data flows back into those systems, or do you see those EHRs extending out to support care at home models?
Thanks. If I understood your question, it was more about sovereignty or individual personal sovereignty of data or data ownership or stewardship.
I guess whether you see the digital platform being an extension to the EHR or something new and therefore integrates and sends data to the EHR.
Okay, thanks for the clarification. I think if I would go very quickly to this, I think the data, the systems of record will be in the domain of the responsible legal entity. That's the data that they need to conduct what they have been mandated to do or what their articles of incorporation determine. And they will have to justify that. Now, to what degree that data that relates to that person would reside in that system or would be in a personal health store, in a pod or some other store, that's left to be decided. Currently, it's a non-topic, unfortunately. So the EMR or the EPR, patient record, those systems of record will be with the institutions. The data interconnect I consider to be a separate entity, which is purely an interconnect. It's like the telephony interconnect or it's like the bank payments interconnect. They connect and they provide a service, reliability, safety, and so on and so forth, and generativity. So the EPR, EMR will be for the institution. The EHR, if that term is still being used, is across entities, and the platform will be one beyond that.
Thank you. And did that answer your question?
Yes.
Yes. Okay. Any other questions? Otherwise, I'll go ahead. So decentralizing care or push care outside the traditional healthcare setting, that is something that has been a hot topic for quite some time now. And we also see that our authorities are stating this in the visions. And also we had this God and Nära Vård reports coming out, just released last year. Why don't we see this implementation happen faster in the Nordics? And what would you say are the biggest barriers for care at home?
I think one of the challenges is in this, I think we conflate, so the Norwegian and the Swedish and Danish health systems are fairly similar. They are there for people, but we seem to have organized ourselves out into different entities where there is no fluidity in agreeing on at the practical operational level. So as a result, the earlier graphic when I was explaining the previous, it stays in one entity. And because there is no legislation, in my opinion, that incentivizes you to move out and share that data, there is no third party you can talk to. So in an ideal world, I would have loved to see my data being shared or stored at a certain place that I could then serve back to the other person. So the Esther model that was talked about, we don't have those constructs. We don't have a data bank entity, is my take. And if we don't have that, people can't, it's not possible to do it because you don't have the mandate to do that. So that the barriers, we don't have the legislation and we don't have the investors who are going to build that because we don't see the need for people to have that data themselves and govern their data themselves.
Yes, very interesting. I think we can have time for one more question before we close. So I'm also thinking a little bit about reimbursement around these therapies. So when care is delivered outside the traditional setting, how do we ensure that the caregivers are given the proper reimbursement? And also, do we need to incentivize patients and next of kin and so on for actually taking on this burden of care?
Yeah, that's a trick question. So I'll just try to answer it with this graphic. Because I think costs, reimbursements, in our part of the world, we have a health insurance scheme. We don't call it health insurance, but it is a single payer health insurance. Your tax money goes in, you pay a co-pay, as opposed to in Germany that they have a multi-payer system. So I think the first thing is, I think we need to recognize what is in your health plan. What is the social contract? Because, you know, are you going to cover cosmetic surgery? Are you going to cover, where do you draw the line? So we need a better understanding of health plans so that whatever I spend out of pocket could be reimbursed if legislation so decides that. But otherwise, the health system should allow you to, the financing should allow you to do, should allow for that kind of reimbursements if needed, because the reimbursements will go to the health workforce. The GPs will also get paid to do their work. The hospitals get paid to do that. So we need to look at that, how healthcare is budgeted for. And that is what I was trying to denote with this slide.
Yes. So we are now at the top of the hour. So I would like to thank Francis with a big applause. And it's also time to